So hello, everyone, and welcome back to the Pursuit of Health podcast. I'm your guide, Dr. Eric Fethke. I'll be your host as we have been through the past 3 or 4 episodes. And we decided to do something now that I hope is interesting and a little bit innovative. And I hope everyone who's listening finds it to be informative. What we thought we would do is take a step back and kind of do a retrospective and look back at the prior podcast together and just sit down and talk about some of the themes and the lessons that have come out of those. So I have some guests with me, join me to have this conversation. One is Dr. Emily Brown, a pediatrician, a practicing pediatrician with Middletown Pediatrics. And the other one is Alyssa Shannon. She's a first-year medical student at the Touro University Medical School. And what we thought we would do is really sit from the front line view instead of, kind of from way up here and analyze or just let it go by, but really step back and look at those common lessons that have come out of these prior podcasts. Because I really think a lot of people are saying they're getting some good information from them, and I'm hopeful that will continue. And so I'd like to wrap this with the concept of the 3 E's that I referred to in our opening podcast episode. And the first one being empower, empower really being education. And I think our guests are teaching us a lot of new things. A lot of people are reacting and saying, I really didn't know about that. And that was very interesting, or that really changed the way I think about something. So I think the empowerment part is starting to really build up, and I'm very excited about that. But this part here is the second E, or the engage, where we talk, where we engage about what do we think? Did that make sense? Do we agree with that? Does that resonate with us? Is it something that we on the front lines who are practicing or training think has merit and really is the right direction for us to go or to go away from if we talk about some things that are or are not working? And then eventually that will lead to the third E, which is to evolve and to actually get up off our seats and go change the way we do things or actually act. And so we'll do that. We'll go over the questions from the first 3 episodes. The first one really being the background to the podcast as a whole, talking about those 3 E's in our concept, and also about the insurance system and how we have so far financed and paid for this and what we're getting for our money. The second episode was dealing with child life, which a lot of people didn't know about, and looking at how the child life profession interacts in healthcare and really changes a lot of the way healthcare is delivered to children. And the third one, which just came out today, actually, and is airing, is the episode on autism from the Center for Discovery, and another group who has really made some big strides in healthcare and in a very tough area and really changed the dynamics there. And the fourth one that we're going to talk about is sat down and talked with Lisa Sassy, who is a nurse on the front lines of a large public school system in the middle of the COVID pandemic. And we thought that that would be interesting to talk to, and we learned a lot from her. So if I look at some of the themes that we came by through these and just review these with all of you, I thought we would talk about them. So in episode 1, we talked about the healthcare system may have lost its way in terms of where we are actually going compared to where we started, with the idea of the Blue Cross Blue Shield being an equitable system that everybody had access to. So some feedback on that. What do you all think about the idea that were we heading in one direction, and are we kind of off that path at this point? Or are we still on it and just need to be a little bit more certain? Or what do you think about that?
So I have to say, one of the big things that I have found that has changed over time, and we touched a little bit on it in the earlier episodes, is how healthcare is dictating what we do as physicians as far as the insurance companies go.
Right.
As a pediatrician, you try and individualize care based on the patient, but the insurance companies are dictating what antibiotic I can and can't give, what studies I can't or can send my child for. And it really restricts a lot of what I'm doing and a lot of what I learned in training going forward. So I have to modify how I practice. I have to modify how I treat the patient based on what's going to be covered And sometimes that's not the best way to practice medicine. So in some aspect, I think we have gone a little bit backwards. We have gone a little bit away from what our ultimate goal was, that we wanted to provide this care equally to everyone. And that just doesn't happen anymore based on whether you have state insurance or private insurance or no insurance and you have to pay out of pocket. Sometimes dictates how we're practicing as physicians.
So the financial model, the for-profit system, does affect the interaction with you and the payer, and therefore ultimately
Absolutely.
what your options are for your patient.
Absolutely.
Yeah. And that kind of is not what we were heading for. And I know Alyssa's just starting now, but I don't think when we trained, we thought that was going to be
not at all.
The fact.
We learned how this is how you treat a patient, and every patient is treated differently.
Right.
And now it's almost like a cookie cutter recipe that if you have an ear infection, this is how you treat it. This is the antibiotic that will be covered, and you can't steer away from that. And sometimes, you want to treat the patient individually, but based on their insurance, you have to make certain decisions, and sometimes that makes it difficult.
Yeah, I think, Shannon, Alyssa, when you're looking at this, and we talk about socialized healthcare, and people say, I don't want that because I don't want that cookie cutter. I don't want them to tell me what to do. The people, the government, the administrators to tell me what to do. But Dr. Brown is saying, but the insurance companies are doing the same thing now. What's the difference? And that's an interesting question. Is ultimately, we're still in that same place we didn't want to be. So what is the difference if it is an insurance company dictating what you can or cannot do versus a system at large, a socialized healthcare system that regulates and makes everyone fit one model? And there's a pro and con to that. And the con is that you lose the ability to individualize and have the freedom to deliver care you want. So what do you think about that idea that, the private payers and insurance may be getting us towards a model that people say they don't want socialized healthcare, but we may be going in that direction anyway, inadvertently?
Yeah, I think what Dr. Brown said is absolutely true. And as far as the training, I'm taking classes right now and I say, okay, if this patient comes in with XYZ, we want to get a CT scan. But, from your perspective, not every patient, the insurance companies will say, oh, well, this patient needs a CT scan. And so it turns into sort of this battle, which I found really interesting about your conversation in the first episode, and learning a little bit more about the insurance companies and how they really developed. I think it came from this viewpoint of equitable care, kindness, compassion, empathy, everything that we really exhibit and are trying to incorporate into our healthcare, at least on the front lines.
Right.
And it got a little twisted because I don't think that healthcare is meant for our economy. I think it's kind of darkened it a little bit. The fact that, in order to survive, you kind of need to be getting a profit because you can't really go under. So it really comes to a question of, should we really be putting wax in our healthcare system?
Right. Should
that be something that we need to do?
So in some sense, you're in your first year and you're already seeing the interaction of something that Dr. Brown and I probably didn't start to experience till we were in training and residency in a level and realized, okay, there was this issue about will this be approved or not approved, and will the insurance company say yes or no? And that was just a glimpse of that. You're a first year medical student, you've already seen it.
Right.
So there's an evolution in a direction that perhaps is not good. Maybe that is a clear sign already that we've gone in the wrong direction when our first year medical students are already aware of this as a problem.
Right.
Yeah.
And to me, that right here and there, that's an eye opener, because I don't think that was even on my radar as an issue, and nor perhaps should it be. Maybe we should be protecting in some sense. I want this dialogue at some point in your training, but right up front,
Right.
That's a little bit disheartening, and I don't want them to do that either.
Right.
Because that can turn the very optimistic and altruistic student into someone a quick pessimist, I would think, if you start seeing money as the impediment here. So in some sense, that profit issue has gotten in the way, right from the education standpoint and the delivery.
And even when we're teaching the students, it's interesting because I don't know when you're teaching your students, but even when we're teaching the students and we're making those decisions, I say, so this is my differential, this is what I want to do, but I have to be mindful of X, Y, and Z. And if the insurance company doesn't cover the CAT scan, then maybe I have to start with an ultrasound first. And then if the ultrasound shows this, then maybe they'll let me do the CAT scan, even though the CAT scan is probably the first thing that I want to do to rule anything out. So it does become part of my discussion with the students.
You're teaching them differently.
Yes, you're teaching them differently.
Already.
Yeah.
I think most people wouldn't know that.
Right.
And I think that's very helpful. The second thing we covered in the first episode was trying to get back to the patient-physician relationship, that if you focused on that, that's perhaps where we should be centering all of this and not just give it lip service, patient-centered care, but really the idea that if we focus on how we want to deliver that treatment, and which treatment we just talked about we want to do without all the restrictions, but to some degree, how we do it is based on our relationship with our patients. And my concern was that we're not being given enough time because of the finances to make that relationship, and therefore we're getting away from the patient-physician relationship, which is not creating a very good product in the end if the product is a good outcome in health, which means that we're spending less time not getting to know what might really be going on, and then actually writing tests and scripts that may not actually be 100% what is needed because we just we have the constraints. And so we've gotten away from that patient-physician relationship model, which then leads us astray as well.
Right. And it's interesting too, because since COVID happened and we've switched gears a little bit, we're offering telehealth a little bit more. Patients aren't coming physically into the building at all times. That also alters that interaction with the patient, that you have less time to communicate their wants, their needs. So you try your hardest to engage the parent and the patient in every encounter and try and get as much information in that little time that you have. But yes, in the back of my mind, I'm saying, okay, my next patient is in 15 minutes. Let me move it along and try and get this whole visit wrapped up in 15 minutes when I really want to stay there and find out, well, how this patient is feeling, what's going on, why they're really here.
That sense, Alyssa, I think that a lot of us don't want for you, which is that sense of not having completed the job before us. And I don't mean a job in the sense of something, not important, the vocation to do what we are trained to do and want to do. Like to say, well, I wish I had more time because I could have. That's not a good feeling.
Right.
And we don't want that for the next generation of healthcare. We want to find a way that doesn't happen as much anymore. And then we can be creative about how that works. But that little pit in your stomach that says, I didn't finish that. And I'm wondering if there's something more going on, but I don't have time. Right. Because the finances are constraining that and ways to that. And, you'll see that in your clinical rotations too. But I always joke about what page was the doctor's hand on the doorknob.
Right.
And I forgot that one.
Right.
Where did that come from? I missed that class.
Yeah.
I don't think you got that class yet. But so what do you think about that? The idea, whether you talk about in your classes about the patient-physician relationship as the center, that's where it starts. So
I think the unfortunate thing, I guess, about our training right now is that we are kind of still getting a glimpse of, my next patient's in 15 minutes. So one of the classes I take is called physical diagnosis, and we kind of look at, your actual evaluation of the patient. Like when you see certain diseases, you're sitting down in an office, you're asking the patient questions, seeing what's going on. All of our exams are timed. And they're set at 10 minutes.
Yes.
They're 10 minutes.
Yes. And in 10 minutes you can't get off the history and physical.
I have colleagues that are amazing. They're so personable. They want to know everything about their patient. Right. They really do. They're so invested in having this relationship. And they get stuck halfway through their actual evaluation because what they really want to do is talk with the patient for 5 minutes and say, okay, how are you? Like, what's going on? Tell me everything about, because, patients like to be listened to, and you want to have that.
But as a teacher and student with you all as our students, in there comes so much of the kernel and the foundation for your care. Once you start having that interaction, that relationship, it changes the way you will deliver care to that person. If you can't establish that relationship, then it's technical.
Right.
It's no longer healing. It's just, a doing. And anybody could do that. But we're trying to train you to be a physician, not somebody who just has 10, 15 minutes and doesn't know who that is. And then the patient feels the same.
Right.
On the reverse of that relationship, it's like, well, they didn't even care to know who I was.
Right.
So,
it's a conundrum because in our class we talk about how important it is to establish a relationship with your patient and really get to know them at that deeper level that is better for care. But at the same time, you're told that you only have 10 minutes on the test.
Yeah. And it's an interesting dynamic because I've sat in on some of their tests, and something that they're graded on is empathy. And to be able
and
in 10 minutes,
5 minutes to empathy.
Right.
I'd like you to be empathetic.
Right.
I'd like you to be very deep.
Yes. But I only have 5 minutes to ask you why you're here.
Right. And can you be funny too, please?
Yeah.
It's like we got to do all that in 5 minutes. It's very interesting because this is a relationship, and we enjoy it when we have those relationships. So I think we're resonating on that, and I think that's a good lesson to look back at from the first discussion, and I was hoping it would take off in that direction because we're all in agreement that we think the financing is not quite working. It's taking us away. It's cutting our time, which is also affecting our patient relationship.
Yes, absolutely.
Right. So I think we all in agreement on that one.
Yeah.
So
something else that I also found interesting and wanted to mention is more so than establishing that relationship. I think you talked about in the first episode, getting a team together for your patient because the insurance company said no, basically, to what the patient needed.
Right.
And, me as a medical student, a lot of us have time in healthcare field before actually going into it. I worked at a cancer center and I worked really closely with nurses in clinical trials. And, I saw it a lot. Caretakers going out of their way to try to convince insurance companies that no, the patient needs this. Right. And ultimately it goes back to, it takes time out of the day to have to fight for your patient. And it's a very amazing thing to do and actually, be a doctor on the phone. It's not supposed to be part of our job description, but now it is. We have to fight for our patients.
And the question is, does that ultimately make sense when we're looking at the system and stepping back from those experiences that you've had in your research and we have? Does it make sense that we're spending time this way? We talk about, not having enough time on the one hand with our patients. We're certainly spending time elsewhere away from our patients too. Give me half of that back to my patient.
Yeah.
Yes.
And I could change a lot. Yes. All right. So and I think that's a theme that's going to come up both with the financing and the time, and time being a precious commodity. We're not spending it well, both of them. And that is, we think we can do it better.
Right.
Yeah.
Give us that back somehow and let us show you what we can do, how we're trained initially to do it. Let us get back to that element because that's how we're trained to do. And if you let us do it and give me 5 more minutes, 10 more minutes, and a little bit more money so that I can do that, watch what could happen.
Priceless.
And that's what we're trying to say. Is like a little bit could mean a huge change in the outcome. So very good point. And then, on the second one, the child life, we broke that down because that was a very exciting session. And Miss Kelly and I really can talk as, she really can, we just spent hours together and talking about all the different implications of a field that is so little known. And I'm really glad that a lot of people said it opened their eyes to that. And she does a wonderful job at Montefiore with that. And so her idea, and we'll see that in the third podcast in autism, but also the idea of family-centered care as a focus. It kind of goes back. Now we're not just talking about the patient-physician relationship, but here in pediatrics, and not just pediatrics, in your cancer care, whatever, the family. There's a family there. So bring the family into it. What do you think about that?
I think that's a fantastic idea, because a lot of how the patient is feeling revolves around the environment that they're in, the support system that they have. So even getting the staff involved, which she talked about, how the nurses got involved and the techs got involved and everybody got involved in the patient's care, it almost empowers the patient a little bit more that they have all of that support and that they are being cared for. And we're showing them that it's all about you right now and we're here to take care of you. So I think that bringing the family in is a really big part of all of this.
And being consciously about it, not just like, giving a lip service and saying it, but to really make that part of how the care is delivered.
Right.
I thought that was very interesting the way she did that. And here we are in a time of pandemic and isolation and people feeling isolated and alone, the kids in school, and now somebody's sick and alone. You certainly know as physicians and students physicians that the emotional and psychological and biological interactions of that isolation and feeling like you're in it all alone is not going to be conducive to getting better.
Absolutely.
And so bringing the family in, or the community, or whatever support team there is around there, and then making the support team and the family all one, I think she laid it out very nicely. Yeah. And you had some ideas about that?
Yeah, so I think that episode really started a common trend that we're going to see throughout the episodes of this podcast, which is really education, the first E. It's so important. Not only does your patient need to be educated, but they need to be educated in a way that they understand. And especially when we're thinking about children and how we care for our children, they don't know a bunch of crazy out there terminology. You need to explain it to them in a way that they really get it, while also making sure that, the parents understand. And how do we reach them on a level that they get it and they feel safe? Because if the parents don't feel safe and they feel anxious for their child,
that now lately. Yeah.
Children are sponges.
Children pick up on that, absolutely.
Yeah, they're gonna pick up on it, and it's gonna make them way more nervous, and it's not gonna be good for them getting healthy. Right. They need to be in an environment where they feel safe and everyone feels assured that they're getting their care, and we're looking forward to the best possible outcome.
And so, and how much does that cost? We're gonna go back to that, right? Mom and dad, come on in, and how much are you charging me to come on in, right? Right, there's no cost to that. So and already your outcome, and she shows that in the research she does. She talks about creative solutions in the current healthcare environment and how she had to kind of step back and figure financial ways to wiggle out, in the CAT scan room. Okay, we don't need you. Just me and this person. And that saves money, and I want part of that to pay my salary. Why did she have to do that? But the idea is, we're already saying, if the family isn't there, that's a free thing.
Absolutely.
Look what happens. We talked about when I was at Columbia, they brought the family into the operating room.
Right.
And they called it the clown program, and the clown was there in the anesthesia, and the mom got to walk in with the kid. And they found they used less anesthesia.
Right.
Okay, how much does anesthesia cost?
Right.
All that stuff. And the kid went down and out of the anesthetic better. And they actually covered better and did everything. Oh, my gosh.
Right.
How much did that cost? Nothing. It saved money.
Yes.
This is what people don't understand. With some of these ideas, we're not talking about money all the time. Or at least an expense. We're actually perhaps getting better care for less.
Absolutely.
There's a theme coming through a lot of this, which I think is very interesting. So I think that does tap into, that's probably one of the same thing as creative solutions that she suggested to try to deliver care that can deliver better care, perhaps for less. And the fact that you have to struggle to do that. Why is it that you have to be on the phone? Why is it that you think about, well, how can I get paid for what I do, when what you're doing is making the care better?
Yeah. And I think one of the great things about what Megan Kelly really taught us is it's all in the strategy. And so now when she is going in and she is talking with that child about how to manage their anxiety and how to, sit in phlebotomy and sit still and get that blood taken, it kind of goes back to that idea of, our children are our hope. They have that for life now. And that's a lesson that they can teach over and over again. And something that reminded me of is our recent kick for mental health and how important that really is. Because a lot of those strategies really just reminded me of like cognitive behavioral therapy, and you can feel when you're anxious and what do you do about that?
Right.
And I think that's really important.
How do you pick up on that? First of all, be sensitive enough to see that, which is what Teresa Hamlin talks about with her autistic, to pick up on the cues. Well, pick up on all of us. You know, can you realize? We walk by someone, and we go, man, they really look depressed today. They really look anxious today. And what do we do with that? That's a clue. That's a signal. We always used to tease my students that, if you walked out of a room and you just felt like, oh my God, I feel so sad. It's like, well, maybe your patient was depressed.
Right.
Yeah.
Don't
ignore that clue. Now what do you do with it?
No, right.
Yes, that's a signal. And how do we reach there and empower them to get out of that? And that's part of our job is to not ignore that, because it's going to directly affect their care ultimately. And I think you bring up a good point that, the empower and the educate, that's what she was doing.
Yes.
Yeah.
They're intertwined. I mean, these people walked down power because she taught them and everybody around them. And then it, that whole ball thing in South Africa, that was just, I was bawling during that time. And that idea that, it just hit me that you just blew this into in kind of a never-ending explosion of empowerment there for everybody who was in that room. They just took it forward,
right?
And that education and empower and doing it together as a community. These things are not separate ideas. We're hearing them from people, but they're starting to come together,
right?
Which I think is very interesting. And children is hope, and the fact that this whole concept she brings up also evolves. It didn't start that way. She didn't see it that way, but the child life and the autistic, a journey that we're doing here together through this process, and that they did. We're watching their journey and taking our own journey through this. That it's an evolution of thought, and you keep what works, and you move forward, and what doesn't work, you move aside. That's how everything evolves. But the ability to do that is not only nice; it's essential for us to be successful. So then we went to Teresa Hamlin's session, and she talked about individualizing autism, which I just blew my mind when I read her book. And I thought about that. You think of, grouping all these kids into one category.
Right.
And boom, she goes, no.
Right.
We've learned it's not.
Right.
It's very different, and they're all very different. And there are some commonalities, but we're going to individualize this. And in the individualizing effort, we're going to help them by doing that. That's actually not, kind of cute to do. It is becoming essential to actually helping them be better. Yeah. So I thought that was very interesting. And you were talking about that too, Emily, about individualizing care.
Yeah, it goes back to every patient is different, and you have to treat the patient as the patient. And just like she said, give me a definition of autism. Well, I can't just give you one straight definition of autism. It's a multi-system definition, and each kid has different aspects of what's affecting them and how they need to be treated and cared for. So I think that.
And you got 15 minutes to do it.
Right. Right.
Yeah. And so obviously her thing takes time.
Yeah.
And so they built a facility.
Yeah.
They built a place, a center.
Yes.
Think about the implications of that for the kind of, we're calling it medical home, and we're trying to wrap our mind around what that means. But to me, that's what the center is. They built a center where all that happens. Alyssa, you alluded to that too in the first podcast, where we said, you had to grab all the different create a team to tackle that boy's surgery for his scoliosis. That's a medical home.
Yeah. That's
coordinating care for that person and bringing all your resources. It can be in one place, or it can be a team of people who know each other and can create that kind of dynamic as well. And that's where you have relationships with each other's colleagues and stuff. And you don't want to be confined to say, well, you can't do that because they're out of network.
Right.
Right. Yeah.
When that's the best person for them to create that team.
And medicine is constantly evolving. So it was interesting how she spoke about, the diet changes that can affect the children. the strategies for when these kids are having meltdowns that we think they can't move forward, but they physically are having reactions that are keeping them from moving forward, and educating people that are caring for them of what's going on instead of just assuming is priceless.
So the center became the staff, that it's not all about the doctors.
Right.
I know we'd like to think it is, but it's about that. And we just had a whole session, with a wonderful nurse. It's about the nurse, the doctors, the assistants, all the other people in the system. And how much they talk about that. Alyssa, you're training to be a doctor, but what's your sense of, how others come into healthcare?
I will say that it has been a recent push in medical education to do these interdisciplinary programs. So right now I'm taking a cultural competency course, which is great off the bat. And we also have an interdisciplinary project, and we're working with students in nursing schools and in pharmacy schools. And I think they're even working on expanding that to physician assistant schools as well. And we are tackling some issues that some patients face. We haven't gotten into the dirt yet of exactly what we're doing, but one of the things that we're thinking about doing is nursing homes. And how did we get where we were with the COVID pandemic? And how can we all work together in our individual fields? I mean, you think about a pharmacist, you never really think about what does a pharmacist have to do with the state of the nursing home, but it's a team effort.
My goodness, and the medications these people are on and the interactions, and we certainly, they've mandated that we communicate with each other through our electronic charts. I don't know if people know that, but they've connected us through there, and we're supposed to be mandated to use the chart to communicate with them. How about, hi, Mr. So-and-so, Mrs. So-and-so, I'm your doc, you're my pharmacist for your patient.
Right.
Let's not lose that. Let's, otherwise they become, a button on a screen instead of the person that really is a big part of the care, who watches our back on the behalf of the patient. Absolutely. Hey, did you really want this? Did you really want that? We don't want to lose that.
Right.
That's a very valuable thing, that concept of creating a team there. And then she talks about, all this has to be founded on evidence. Not on hearsay, not that, what I think or what I believe, but what I know because of proof.
Right.
Going back to the science, and we're all living through that right now. But I think that she's evolving a very complex world for autism and using evidence to do that. And I thought the implications that if she could do that with that center and with evidence for that group, what should we be doing for other aspects of healthcare?
Exactly.
That model.
That I thought of the same thing, because when you're talking about evidence basis, the whole idea of her center, to me, I kind of saw a microcosm of what we could have. What could our healthcare system look like?
Yeah, that's what drew me to that conversation. Absolutely.
Yeah. How do we take that and how do we spread that out? How do we make that for everyone and not just this group, but what aspects do we need to add to our system? What values are there?
Right. And I think that's why the idea that, and I think, we were talking about it when she was like, you're right. That's why we're building the hospital. It's not to increase our bed supply, as we were talking about. It's because we want to take what we've learned and the implications go beyond here for anxiety, for Alzheimer's, for all the other things that are going on in the neurocognitive area of our world, right now. And how can that, the lessons learned in that center be emulated and grown from there? What's working and take it outward. And I thought that, that's important to just say, I'm not going to hold on to this because, we're going to make a profit on this, or it's got to, but no, we got to share what works and what doesn't. And we got to choose those centers of excellence. She said, we're a center of excellence. Well, what does that mean?
Right.
Yeah.
It's a plaque on the wall? No. It's like, look, isn't that pretty? No, it means that we have now a responsibility.
Right.
To share that and to teach that and do one, teach one, move, move forward. That's our field. And it brings us back to that element, which I think sometimes we get away from a little bit. So the last most recent episode was with Lisa Sassy. And she was talking about, being a nurse in the middle of COVID. And she basically kind of made me think before we got together and we talked a little bit more about this, is that, we're talking about who delivers the care, who organizes the care. Is it the government? Is it a private industry? All that stuff. And then I was talking to her, I realized she's a public school nurse, which is our government. It's our local government, our state government. It's funded through the system. And we're trying to do that through COVID and coordinate. And we talked about that in the podcast episode. But really what I started realizing is that public/government thing with a nurse in education. Education and health are entwined.
Yes.
That was, I think, the lesson I got out of that, is that's sometimes that's the inroads to the healthcare system, is through education again. Here we go back to that empowerment again. Mm-hmm. And I just, I don't think I thought of the school nurse as anything other than the person you go to when you don't feel well and send you home.
Right.
Right? And it was much more than that. Especially now we're starting to appreciate that. But I hadn't heard a lot of conversation with school nurses. I know we focused on teachers, but I wanted to focus on nurse there. And so what do you think about that idea that perhaps the first time that a kid gets referred to a doctor, or comes into a new community and wants to know, or they're sick and has an interaction either with a school doctor, because I know you're a school doctor as well. I mean, think about that. Public. So you're a school doctor, you're covering a school, and she's a school nurse there, and you're working together. And this is our public government-run system. So we're okay with that, right? I mean, we're proud of this public education system, but I don't think many of us thought about it from the health side.
Yeah, and it definitely goes hand in hand, because you do have those children that come from a different state. They don't speak the language. And there's that barrier there right from the start. And sometimes it is that school nurse that's reaching out to the pediatrician. I don't know if this child is well. I don't know if this child needs this. If this child is autistic, if this child has a learning disability, if this child has a speech impediment. So sometimes they're the first ones that encounter that patient that they're referring to you. And now you get involved from the healthcare aspect because the school nurse or somebody at the education level was the one that picked up on this.
Right. Yeah.
So yeah, it definitely is entwined. And now that COVID, came into the picture too. So now they're educating our families about COVID and what they need to do to care for their families, to care for their children.
Oh, her phone is off the hook, and I'm sure yours is too.
Absolutely.
Become a huge resource in your school.
Yes.
I just don't think most people think of it that way.
They're teaching. If you go on any school website right now, there's a COVID section that the parents can go on and look for answers to questions that they have about the illness, what to do with their family, how to quarantine. So
it comes back down to the idea that, we all work and spend as much time at our work as we do in our homes, and kids in school as much as they're home. So that's where you notice things. And we all want our kids to be where somebody's watching them and taking care of them. And there was a time when they tested out for a while, I remember, before Alyssa, when people were talking about the idea of having a physician or a health system in the company.
Right.
And we kind of got away from that. Right. And somebody said, well, that may make sense. It might keep people at work. It might make them healthier. It might be more conducive to them going and being compliant because it's right there in the office. And we kind of went away from that. Right. And Lisa is saying, I'm the nurse, and it helps them where they spend most of their time. Why wouldn't that work in employment?
They're there for 6-7 hours a day.
Right.
They see everything that goes on with that child, from their physical health to their mental health to their emotional health. Right. They are the front line for those kids.
Gotcha. I think that, there's two questions that came in from outside as well that I just like to quickly touch base on, and then wrap it up with one summary idea that I think we're all getting to. I'm trying to pull that out of this because I think we are all kind of in agreement, and Lisa alluded to this in the end. But a question came in from a gentleman, DR, online, response to the first episode. But I think these all start to intertwine. And that's I don't understand. There's the question. He says, I don't understand how the financing, isn't the first thing you think about. When you're trying to build something, and healthcare is to some degree a business, and you do have to think about how you finance it. So I don't get it. I said in the podcast that you build it first and then you pay for it. How does that work? That doesn't make sense from a business model. And, I had some responses to that, but I thought, how would you answer that question?
So going back to that personal sense of providing empathy, providing care for your patient, unless you build that relationship from the get-go, you can't worry about the financial yet. You have to build that relationship. You have to show what your services are before you can say, this is what I'm going to charge for X, Y, Z.
So on an individual basis, you can't be thinking money while you're delivering care. Right. And once all that time clock comes into your head, you're kind of forced to do that. So you're saying that's getting in the way now.
Right. Absolutely.
And I think that's where the money becomes interfering. And if you give me a little more time, then I can actually save you some money.
Right.
Mm-hmm.
So focus on how I do my job, and I'll actually make the finances better than we're currently doing.
Absolutely.
And I mean, you're just starting out, but you did it in your research and you saw people finding. So what do you think about the idea? Does healthcare work on the same model as perhaps another business, where you put the business pro forma out, as we say, in the accounting, and then you say, okay, and then you put the product out.
Mm-hmm.
Does healthcare work that way?
I mean, even taking it away from healthcare, think about the kinds of things you see on Shark Tank or something.
Mm-hmm.
Like if you have a new entrepreneur starting out, you don't start out saying, okay, I'm going to spend $5,000 on this product. You have to think of what the product is first. What do we want? What do we want this to do? How do we want this to work? And then you put the pieces together and say, okay, well, what is the cheapest way that we could do this? What makes the most sense financially?
Well, not necessarily just the cheapest, but where do we get it both? Where does the price point meet the quality point? And do we think we're there right now in healthcare? Do we feel like that?
Yeah.
I don't think many of us do. And I think patients know that and feel that what we're buying for, as we said in the first one, for our money isn't really what we want. My answer, my thought to that was, the money is being spent. Mm-hmm. It's out there, but we're not spending it well. It's not a matter of spending more money. And perhaps, as Megan Kelly said with her model in the CT scan, and get rid of all these extra costs and all these people, actually, because you designed it the wrong way, you're actually very wasteful in spending more money. If you had asked how to do it this way, I would have saved you money and given you a better outcome. That kid's CT scan will be a nice, better picture and a better experience for that kid. And we all know that.
Right.
The kid's not screaming on the table anymore. So you saved money by focusing on how you did it rather than how you paid for it first.
Yeah.
And the whole dialogue is lately about insurance and payment in the political realm, but they're not asking, what are you buying for this thing? And I agree. I think we're all saying, I want to tell you what I want you to buy. I want to tell you this is what all the guest speakers are saying is, let me show you what we can deliver. And I will tell you, actually, that'll give you a better product and probably a cheaper than what we're doing now, when it's all kind of hodgepodge and not being coordinated very well. She's saving money there by doing that. You're saving money by lowering the anesthesia when the parent comes in the room, or when it's family-centered care, or all these things. And we actually feel there's a lot of waste as practicing physicians in the healthcare system financially. That doesn't need to happen if they just gave us a few more minutes and stuff. We could save you money, order less tests, do things. So the answer really is the financial is not being ignored, but it actually shouldn't drive how we deliver care, because it actually doesn't know what it's doing, with all due respect, and it's creating a wasteful, poor product, and that's why we rank so poorly in this compared to other nations.
I mean, just think back to a point that Dr. Brown brought up, with now you have to order an ultrasound before you could get a CT scan. You get the ultrasound to prove something is there. That costs money too.
Right.
We have the training to know when something is needed, when we need to see what's going on.
So what they're worrying about is that the CT scan is more expensive than the ultrasound, right? That's what they're worried about. But they're not thinking about, there's a technician you're paying for. Right. There's all the gel and equipment and everything else for the ultrasound. That's not free either, right? But the real impediment, at least as far as the book counter is asking, is saying, well, that CT scan is 5 times as much as the ultrasound. Right? That's what they're saying. So on their ledger, that doesn't make sense. Do this first, and maybe I'll cut down that expensive candy bar that I used in my first, analogy. No, I don't want the expensive candy bar. Just give them that one. And the real question is, why is that candy bar so expensive in the first place? Why is that CT scan cost that much? It doesn't cost that much in other countries. So you start to, you can't ignore that question, right? You have to go in there and go, wait a second, why does the CT scan cost that much? It's not that new a test anymore. So where's the money going, right? You start to track that down, and then you start to realize that there's not only waste, but there may be some profiteering going on. We have to be honest about that. At least as physicians, we feel that too. So maybe the CT scan doesn't have to cost that much, and therefore the insurance person would say, okay, do the CT scan if that's the best test. Now we're turning it around. We're not just giving it, well, that's what it is. We're asking, why is it that way? Because we think that's the best test. And let's say, not only does it save the ultrasound, but saves the life. Which means less illness, which is less hospitalization, which is less money. Even down the road in the long term, less money. So the time frame has to be a longer term time frame in healthcare too.
Right.
If we just do the ledger for this week, next week, healthcare doesn't work that way.
I think even just speaking from a patient point of view, if you're having a problem with insurance and you can't even get a CT test and you think that something is wrong, a common thing that people use for anxiety is avoidance.
Yes.
So they're just not, if there's a barrier there, they're just going to ignore it and go back. But then what happens if you say, have a patient where their doctor was worried about cancer and they step away and, they couldn't get the CT scan, so they don't want to think about it. And it progresses.
Yeah, and then we turn around and we wonder why they're so non-compliant. And we turn around and blame the patient. That's a great patient-physician relationship to go down, right? So it goes back to that again.
Absolutely.
Yeah, I think these are very common themes. And the last thing that Alyssa brought up, Ms. Sassy brought up, or Dr. Sassy, she's a nurse practitioner doctorate, so we give her credit for that, is that the confusion of people saying that the system is not uniform. It's not consistent, whether it's community to community, whether it's picking up the phone and calling somebody at a health department, getting a different answer from different people, or having one rule for this school system and a different one for that system. So COVID itself taught us a little bit. And she said one of the things that she really believes can help is some more consistency amongst our healthcare delivery and our standards and our guidelines, and that we all follow these. And I think we all feel that as well. And that was a question that came in from somebody by initial BS, and she said, why is it so complicated? Why is it so different depending on where I call? And I think Dr. Sassy addressed that is a problem. And if we can improve that and make things a little more consistent within our own practices, within our own community, within our school systems, within our own states, that could do a lot better.
Absolutely.
Yeah.
Absolutely. It ties back into that communication between one system and another system, and the education and the healthcare and how they go hand in hand. And those nurses are teaching our community what the proper protocols are. And if one school district is teaching one thing and expressing it one way, and another school district is telling you something else, and those two families come together and talk, well, my school district said this, my school's, if we had the communication within all the school districts and everybody was on the same page, there wouldn't be that confusion. So,
leave it to Dr. Brown to tie the whole thing together. Right? You're right. The idea that we went back, you're educating through the public healthcare system, through a nurse teaching people about healthcare.
Right.
And you want it to be consistent, so they go out as citizens and people of our country accessing our healthcare system in a way that is consistent and makes sense to them. And we're trying to teach that from the beginning. And we just need to deliver that in a way that's focused on them. Oh, so simple, right? But these are the themes that are coming on. It's true. It could start right there with the education piece, and we raise our society. We educate our society this way. Their expectations start right from their education.
I think one important thing that I guess acts as sort of a counterpoint is we need the individualization as well. Not everything that one community needs is something that another will need. So it's a fine line to walk through.
Good point.
You know, we are living in an age of McDonaldization. You go to a McDonald's here and a McDonald's in China and they look the same. But how do we, you know, there's cultural differences between here and China. So how did we modify that to
And they do.
communities?
They do.
They absolutely do.
Right.
So.
The one in France has a glass of wine. Been there. So they figured that out. There's no way you're going to get away without that in France, right?
But yeah, I think that's something that we need to figure out. What parts can we standardize and what parts need to be special?
Right.
Because I think now we have too many things that are special in different places where you could go to the same town and there's two different offices that run completely different. So how do we make that easier for a patient to understand?
Yet individualized. So in there lies the trick, is that balance, finding that kind of soft spot. And that's kind of maybe where we, as we move forward through the other episodes, should be looking at how do we find that soft spot between giving the personal freedoms, the individualization, that what we call, you know, the American system here of individual liberty, and balance that out with the need to have some commonality that creates a good standard as well. Where is that? And how do we get back to that? You know, and right now we may be, you know, in often too many directions because of finances and other issues. But, you know, keep having these conversations, I hope, is how we do that.
Right.
So I enjoyed this, actually.
Thank you.
I think this went into a nice review, and I hope that it ties together the first few episodes as we continue to engage and then eventually decide what we're going to do when this is all there. And so we're looking forward to that. The next time Dr. Sassy is going to be talking a little bit more about that immigrant interface into the, again, the public school system and how that affects health. Next podcast after that, we're looking at is implicit bias in an oncology and healthcare program for children. And how do we, as caregivers, what we bring with us to the bedside, good and bad, and how can we work on that and create that commonality. We'll be talking in the future to someone who talks about nutrition and how the gut really is where the soil and the foundation of a lot of these issues we've already talked about with autism and other issues of anxiety and the other healthcare issues we face, and how we can start that in children. And then there's another physician team we're going to talk about what it's like to be an African-American physician in the United States and what they face as they try to not only be physicians in this country, but also to help address the issues in their own communities. So these are more things we'll talk about. We'll step back and look at those more in the future with the Pursuit of Health podcast. I really think I'd like to thank you for kicking off this first Take a Step Back session, and I hope people found it interesting. And thank you again.
Thank you. It was a lot of fun.
Good. It was great.